Hello, 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 everyone. Okay, hopefully we got this right. I want to make sure that you can see my screen. Please let me know. Testing, testing, one, two, three, testing, testing, one. Okay, type in the chat if you can hear me and if you can see my screen. Testing, testing, one, two, three. All right. Oh, goodness. 'Be here. One, two, three. Testing, testing. One, two, three. Hello, hello, hello. Can you all hear me? Mm-hmm. Ooh, I'm live. I was about to say, wait a minute. Awesome. Okay, they can hear me now. Awesome, awesome. Thank you. All right, everybody. Thank you so much for your patience and understanding. And I think we're going to have a phenomenal class. I do. I do. Are you all ready? Okay. And this is new for me, so I got to get accustomed to these things. So I wanted to get rid of that banner. It's gone. And we're going to begin with the disclaimer. Coders, you know what? We want to do everything for everyone and we just can't. But this presentation is for advanced level coding students. Students are expected to have a strong foundation and a working knowledge of the following before participating. Now, if you are new, feel free to stay and watch, but don't pressure yourself. to, kind of get everything right. No, no, this is for the people that are towards the end of their instruction. You are definitely in part three. You finished part one, you finished part two. That's advanced ICD 10CM, and you're in part three, mid to end of part three. Now, if you're an AMCI MCDC student, you should be in part three. If you're an a la carte student, you should be in part three. If you're an a la carte student, that means you're doing things on your own. You should have completed parts one and two of your a la carte. And YouTube students, you should have completed at least the first 12 weeks. All right, so hopefully that gives you a little bit of insight on where you should be. Now, let's go ahead and talk about the goals of the presentation. Well, the ultimate goal is to learn how to abstract codable documentation from an operative report. Yes, the real deal. And scenarios too, but operative report. This is the real world. And in this presentation, we're going to do the following. We're going to review only operative reports. We are going to discuss ICD-10-CM coding, especially how to get that first listed code. We are going to discuss CPT coding, and we will delve into the guidelines. And we're going to do it, and we're going to integrate our keyword concept. And finally, we're going to give you some practical application. And coders, if you didn't know, this is a 30-30 class. What is a 30-30 class? Well, the 30-30 class is I'm going to do my thing for 30 minutes and you're going to do your thing for 30 minutes and I'm going to stay the entire time and I'm going to be here to answer your questions. So I'm going to give you a scenario. You'll work it out. You got 30 minutes and you can just type in the chat if you have a question and I'll do my best to answer. All right. So last time we engaged in the keyword concept game. And the goal of that game was to get everyone familiar on identifying codable diagnoses and procedures. So we just kind of gave you a little rhythm. And this week, we're going to delve into it. No more games. We are going to discuss these operative reports. And if you didn't know, operative reports look like this. This is the official document that surgeons and doctors use when they carry out surgical procedures. And they look like this. They can have various forms, but they have certain components that are the same. And we're going to discuss that momentarily. But the most important thing in an operative report is really not the documentation, but the authentication. Authentication is how the doctor signs it. This makes that operative report valid. And if you didn't know, the protocol for an appropriate authentication is at minimum the first initial, last name, credential, and date. At minimum, first initial, last name, the credential, and the date. Now, the purpose of the operative reports. Now, we know what an operative report looks like. We know it's the official document recognized where you document a surgical procedure, but we know that the operative report have several purposes. And in addition to being that official document, it also helps to substantiate medical necessity for coding and billing. When doctors carry out a procedure, the diagnosis and the procedure has to match. The diagnosis has to substantiate the procedure, and the operative report is the proof. Also, operative reports serve as a part of a legal record of patient care. Yes, your medical record is a legal document and it can be subpoenaed and it can hold up very well in court. And you better believe operative reports are a part of a medical record. And finally, an operative report is the primary source for medical coders to abstract accurate CPT, ICD-10, and HCPCS Level 2. This is the document that we use to do our job. So yeah, operative reports have a lot of purpose. Now, the structure of an operative report is pretty standard. We just saw that I gave you three different examples of operative reports, but on all three of those operative reports, they pretty much have the following components. They have a heading, and in that heading, they have the patient demographics. The date is there. The surgeons that are participating in that procedure are listed there. Also, operative reports often have a preoperative diagnosis and a postoperative diagnosis. Okay, coders, I got a question for you. This is a guideline question. When you have both a preoperative diagnosis and a postoperative diagnosis documented in an operative report, what do you do? Go ahead and type in the chat. I want to know what you know. And I know you might be a little delayed for me, so I know to wait a moment or two. Absolutely. Vina said post-op. Devana, outstanding. And Leslie, outstanding. And Zolma, outstanding. Diana A, outstanding. Right. So when you have preoperative and postoperative diagnoses, you document the post-op. It's going to take precedence. Also, in that operative report, you're going to see the history of present illness. You're going to see the procedures performed. You're going to see the narrative and the body of the report. And you're going to see the doctor's findings, any complications, if specimen were sent to pathology, and the disposition of the patient after the procedure. Now, let's go ahead and talk about how to abstract codable parts of an operative report. We're going to talk about the do's and don'ts. What is codable? What is not? Generally. Okay, so these when I say generally, and I give you a three small items, these are things that you can just remember. You can, right? So you do code the diagnoses and you will code signs and symptoms when there is no diagnosis, right? You will code procedures and supporting details such as laterality, which side of the body, what's the size of the defect, what's the age of the patient. So these are some things that you can just kind of remember because these are generally things that you code in an operative report. Now, don't. Generally, these are things you don't code. You don't code signs and symptoms integral to a disease. You do not code procedures integral or related to a procedure. And you might say, what are you talking about, Mrs. J? Well, if a person arrives or is having a hysterectomy, then it's not necessary to code excision of uterus. So even if the doctor documents it in the operative report, if the doctor says, I'm carrying out a hysterectomy, you just need to code for that hysterectomy and not excision of a uterus is a procedure, right? Yeah. So it's integral though to the hysterectomy. And finally, don't code separate procedures. Yeah. So if a procedure is documented as a separate procedure, you don't code it with another procedure. So essentially, you should know the separate procedure guidance. So if you don't know, it is throughout the instruction in part 3. So I suggest that you look at it. And if you are a YouTube student, look at the free YouTube course. It's throughout the CPT part of the instruction. Look at this. Somebody's getting ahead of the game, but you know your stuff, Devana. You do. We're going to go over those too. Now, this is an up close and personal of a standard operative report template. As you can see, the patient information goes here, date of surgeons, the date of surgery, the surgeons and the assistants, the preoperative and postoperative diagnoses, the procedures performed, if anesthesia was rendered, the type and the provider. Also, the indications for surgery. That means why the surgery was needed, the operative findings, the description of the procedure, usually step-by-step detail of what that surgeon did, the estimated blood loss, the specimens, the complications, dispositions, conditions, etc. And most important, the authentication. It's got to be properly authenticated, that operative report. Now, here we go. These are things that are commonly not coded in an operative report. I gave you the general. Now, here is the extended list. You're not going to code control of bleeding, such as hemostasis. Not going to code it. You're not going to code suturing or closure of the incision, except if you're coding for skin procedures, like repairs, right? You're not going to code local or general anesthesia administration unless the surgeon is administering the anesthesia, the general anesthesia. You're not going to code draping and positioning of the patient. You're not going to code irrigation of the and wound exploration. That's minor wound exploration. You're not going to code dressing application, access to surgical site. You're not going to code surgical drains, supplies, unless it is used for the treatment. Yes, unless it is used for the treatment. And there's one more thing that I'd like to add. I want to add, do not generally code the things that the doctor observes. Like they'll go in, they'll open up the surgical site and they'll make observations. Don't code those observations unless it's pertinent to the treatment. Just saying, unless he carried out a procedure or something. All right, so I have a quick quiz, and I know some of you were here last week and you took this quick quiz, and I just want to thank you in advance. All right, coders. Of the following answers, what is considered properly authenticated? A. John Doe, MD. B. J. Doe, 8/25, 2025. C. J. Joe, MD. 8/8/2025, and John J. Doe, MD. What say you? You all are rocking. You're rocking. You're rocking. Outstanding. You know what everyone said? Everyone that has answered so far said C. Way to go. We didn't trick you. You are being forensic. So again, the provider must sign with a minimum of the first initial, last name, and the credential and date. All right, we got another quiz. Of the following, what is generally not coded in an operative report? A. Wound exploration minor. B. Diagnoses. C. Procedures. D. Laterality. What say you? Hmm. 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 I think you all are, you are rocking. That's right, Brenda, Devonna, Valerie, Leslie. Oyen. Okay, that's Yoruba. Mustafa, Tahiri, Diana, Leslie, you know what? Thank you so much for giving your responses. But what is not coded is generally wound exploration. And wound exploration is typically incidental to the procedure. So that's basically what the doctor is looking at, right? I'm exploring around to see if anything's going on. If it's minor, sometimes they have extensive wound exploration when patients have high impact, um, how can I say it? Like, let's say a gunshot wound, a bow and arrow, or stabbing. Sometimes they have to go in and explore the organs around it to make sure that there are no problems. All right. So now let's go ahead and let's move further. Just want to remind you, you will need these items. We're going to be using ICD-10-CM guidelines for, of course, your diagnoses. We're going to be using CPT guidelines for your procedures. And don't forget these Section 4 guidelines, ICD-10-CM Section 4. This is where you're going to really know how to properly code or assign the first listed diagnosis. So, coders, do you all remember? In part one, we talked about these Section 4 guidelines and designing the first listed code. And also, we showed you the first listed code selection chart. So, if you've been following along, that might ring a little bell. And if you haven't, and this is your first time, it's okay. Just turn to section 4 and reference those guidelines when asked for identifying that first listed diagnosis. Okay? Now, this is what it looks like. This is what it looks like in the MCG manual and also in the when we're referencing it in the instruction, it looks like this. Essentially, we've broken it down so it's easy to reference. And whatever your circumstance is, you just kind of look here, you reference that circumstance, and you look below for the guidance. So when you have signs and symptoms, look below. But I want to draw your attention to number 5, this coexisting conditions. When a patient, I just want to review that one. When a patient has multiple comorbidities, let's say like they have multiple chronic conditions in an operative report, you're going to have to code all documented conditions that coexist at the time of the visit and or conditions that affects the patient's treatment. So if they have these conditions present, you need to code them. All right, just remember that. Somebody said they love the chart. I love this chart too. I do. All right, so now we're getting ready to get started. I only have 30 minutes, so let's go ahead and let's test your knowledge on operative report code abstraction. So this is kind of where I do my thing, and I'm going to read it. I'm going to show you how I'm abstracting. Then I'm going to give you 30 minutes because I'm going to give you your scenario. And you can also code along as well. All right. Okay. So first operative report. The patient is Larry Dove. Medical record 22222. Date of service. Date of surgery 8/20/25. The surgeon is Roger Federer. The assistant is Daryl Slova. The anesthesiologist, that's Novak Joker MD. All right, so preoperative diagnosis is comminuted fracture right distal radius. Postoperative diagnosis, it's the same. The procedure performed, open reduction and internal fixation, or an ORF, of the right distal radius fracture with volar plate. Anesthesia, general anesthesia with regional block. Estimated blood loss approximately 100 milliliters. No complications. Specimen removed, none. Implants, volar locking plate with cortical and locking screws. Indications for procedure. The patient is a 50-year-old male who sustained a fall onto his outstretched right hand, resulting in a displaced comminuted fracture of the distal radius. Due to instability of the fracture, operative fixation was indicated. Operative findings. The distal radius was fractured in 5 fragments with dorsal angulation. Successful anatomic reduction was achieved intraoperatively. Description of procedure. After informed consent was obtained, the patient was brought to the OR and placed supine on the table. Following induction of regional anesthesia and application of regional block, the right upper extremity was prepped and draped in the usual sterile fashion. A tourniquet was applied and inflated. A volar incision was made over the distal forearm. The flexor carpi radialis tendon sheath was identified and retracted, and the fracture site was exposed. The fracture fragments were reduced under fluoroscopic guidance. A volar locking plate was positioned along with the distal radius and secured with cortical locking screws. Stability was confirmed, and final fluoroscopic images demonstrated satisfactory alignment and fixation. The wound was irrigated and closed in layers. Sterile dressings and a volar split were applied. The patient tolerated the procedure well and was transferred to recovery in stable condition. All right, the doctor signed it and dated it properly. So I'm ready to go ahead and do my thing. Now, my task, I have to determine all codable diagnoses, all codable procedures, and I must identify the first listed code. And if I need to, the primary procedure. All right, so what are you going to do? Well, you know how we do, we like to inventory, but I came up with this chart here. And this chart is just a reminder for me like, okay, Mrs. J, make sure you grab that post-operative diagnosis. Go ahead and indicate your procedures performed. Look in there. Look in the indication for procedure right here. Look in here. This is often your history, right? The history of the present illness. The operative findings, look in there. Was the anesthesia performed by the surgeon? No, it was performed by the anesthesiologist because Dr. Joker is the anesthesiologist. Was it authenticated? Yes. Was image guidance? Did image guidance take place? And absolutely it was. And anything else, I'll put it here. So I want you to make your own document chart. You can use mine, and then when you get your groove, you can just keep going. Now, what I'm going to do, I'm going to box things that I believe are codable, and I'm going to also box things that should be notable. So green is for codable, purple will be for notable. And what are notable things? These are things that could impact the code selection. You're not necessarily going to code it, but it could impact my code selection. So here we go. I'm definitely going to code this diagnosis. The post-operative and preoperative are the same, the comminuted fracture, right distal radius. I'm also going to box the procedure performed. An open reduction with internal fixation or ORF of the right distal fracture with volar plate. And whenever you see plates, like screws and plates and things like that, that often is an implant. Sometimes that's important, sometimes it isn't, but it's just important for you to know that that's an implant. All right, what else am I going to box? I'm going to box this right here in the history of present illness or the indication for procedure. I'm going to I'm going to box a fall onto his outstretched right hand, right? Yeah, we might have to pick that up too. And I don't need to box this, but it's just confirming this displaced comminuted fracture. And what else am I going to box? I'm going to box the fluoroscopic guidance. That's pretty much it. To me, these items are codable. Now, what's notable? Well, this volar locking plate with cortical and locking screws, and it's an implant too. See, it is an implant. And why are you boxing that again? Don't know. I don't know, but it's notable. It's notable. All right. Also, too, this fracture had 5 fragments. That with dorsal angulation. So that's notable. That's an extensive fracture. And anatomic reduction was achieved. Coders, what does reduction mean? Anybody know what reduction means? What is another term for reduction? In Part 3, the musculoskeletal section, we review musculoskeletal coding guidelines. And when we say reduction, it also means manipulation. It means that they put it back in place. So that's notable. Also, I thought it was notable that they did go down to the flexor carpi radialis tendon. They went deep down to the muscle, right? And of course they had to because they're working on the bone. Also, alignment took place that kind of supports this reduction, and fixation kind of supports this implant. So it's kind of redundant, but here is my inventory. Number one, this comminuted right distal radius fracture. That's my first listed code. I'm also going to code that fall onto outstretched hands. I'm also going to code the ORF with volar plate fixation or implant, because some codes have that information. It'll say implant, and you need to grab it because this is indeed an implant. All right, fluoroscopic guidance, I'll always grab it because some codes bundle it, others don't. And you know when you need to code it additionally because the parenthetical guideline will tell you this isn't something that you just need to know. So you just have to read. All right, somebody said, absolutely, Diana. She said, this I asked you all what was a reduction. She said applying force manually. That is the definition. And Barbara also came through with that manipulation. Outstanding. All right, so this is my inventory list. Now I'm going to code. And yes, I'm going to look this up. This isn't for the exam, right? No, this is real world. You got to look up your code. So this is up top right. This is my path. This is my code lookup. Fracture is my main term. And radius is a subterm, distal is a subterm, right laterality is a subterm, and comminuted is also a subterm. So I'm going to go to the fracture section. I'm going to scroll down until I find my radius, right? And then underneath radius, I'm going to look for any of these subterms, but right up underneath distal end, see right underneath, it says see fracture radius, lower end. All right, so I need to go fracture, radius, lower end right here. All right, any more? Are there any more subterms that I can locate? And you know what? I can't find any other subterms. So the doctor did specify that this was a comminuted fracture, so I like specified, not elsewhere, classifiable. And I'm going to go search S52.59. So S52.59, other fractures of lower end of radius. And remember, distal is lower end. And if you didn't know it, it defines it right here. And this is the right radius. So we're going to select the right code. And the answer, S52.591A, because I need 7 characters, right? That box said you need 7 characters. So that is my code. I'm going to skip over this fall onto outstretched hand, and we're going to just go right to number 3, and we're going to code the ORF. All right, so my CPT code lookup, this is my path up here. So I'm going to look up fracture. Yes. And we're in CPT, and this is a diagnosis, right? So yeah, you can look up diagnosis in CPT. Fracture, distal radius is my subterm. Open subterm. Internal fixation is a subterm. How do you know it's open, Mrs. J? Because a ORF is open. It's an open reduction, an open manipulation, right? So in your CPT manual, go to fracture. The index is in the back of the manual. Fracture. Fracture of what? Radius, right? And then underneath radius, I'm going to select distal, and underneath distal, open treatment. And it directs me to 25607 through 25609, and that is where I'm going to search. So let's go ahead and search. 25607 is in this section, and 25609. So all of these codes are applicable. So we need to do our reading. It's not 25606 because this is for percutaneous skeletal fixation. Nope, we're looking for an ORF. We're looking for open treatment. So 25607, this is open treatment of distal radial extra articular fracture. Wait a minute. There's no mention that this is an extra articular fraction. So I'm just going to put that on hold, and I'm going to just scurry on over to 25608. This is open treatment of distal radial intra-articular fracture. Okay, so this is within. I like this, right? I prefer intra-articular than the extra. Or epiphyseal separation with internal fixation of 2 fragments. Okay. All right. So 25609, this is open treatment of distal radial intra-articular fracture, right? That's within the joint, with internal fixation of 3 or more fragments. Okay, coders. Even though I didn't list it in my inventory, I did list it as a notable. This patient had 5 fragments right here. So it must be 25609. And I'm looking down here. It tells you do not report, not applicable. So I like this code. Now, we've got our first listed code in our primary diagnosis. Now let's go ahead and code out that fall onto outstretched hand. And how do you do that? Well, fall. And if you're not familiar with how to search for these chapter 19 codes, these are the who, the what, the why. Not why, but how. Who, what, not who, what, where, how. These are your external causes codes. These aren't necessarily diagnoses, but they answer the what, the where, and the how. So this was pretty, all we know is that he fell onto his right hand. That's it. So essentially not a whole lot, just the standard fall code, accidental W19. That's all I have. And this is a 7-character code. And we know that because of the 7-character extender box, or yeah. And we also see the blue, um, the blue box that says, hey, this has to be 7 characters long, right? So to make W19 7 characters, we're going to code W19 XXXX, and then your 7th character extender, which is A. So these are my codes. So what about this fluoroscopic guidance? Well, there was no mention underneath the code that says, hey, code fluoro additionally. There was a parenthetical guideline that said do not. So we're not going to code this fluoro. I want to go back. I just feel like I moved too fast. That's it. That's it, coders. And some of you are probably saying, hey, I could do that, right? Yeah, you could do it. You all ready to do yours? Okay, type in the chat. Let me know. Are you ready? And we're calling it homework because if you don't have time to stay, you may take it with you. And I'm going to ask Miss Mills to give you the homework sheet. She'll put it in the chat. And also, I'm going to read it to you as well. All right. So here we go. The patient name is Jonathan Ellis. Date of birth, 3/14/1958. Medical record 0048291. Date of procedure, 8/25/25. Surgeon, Marissa Langston, MD. Assistance, none. Procedure, laparoscopic cholecystectomy. Anesthesia, general endotracheal anesthesia. Preoperative diagnosis, symptomatic chole. I always choose these scenarios and I always have a hard time. Cholelithiasis, chronic cholecystitis. Postoperative diagnosis, symptomatic cholelithiasis, chronic cholecystitis. Type 2 diabetes mellitus with neuropathy, hypertension, obesity, CKD stage 3. Indications for procedure. The patient is a 67-year-old male with a history of recurring right upper quadrant pain, nausea, and intolerance to fatty foods. Imaging studies revealed gallstones and a thickened gallbladder wall consistent with chronic cholecystitis. Given the persistence of symptoms and increased risk of complications, surgical removal of the gallbladder was recommended. Operative findings: distended and thickened gallbladder, dense adhesions to omentum and hepatic flexure, no bile duct injury, no operative complications. Description of procedure. After obtaining informed consent, the patient was brought to the OR and placed in supine position. General endotracheal anesthesia was administered. The abdomen was prepped and draped in sterile fashion. A Varus needle was used to establish pneumoperitoneum. A 10 millimeter trocar was inserted at the umbilicus, followed by placement of 3 additional trocars under direct visualization. Dense adhesions were encountered and carefully lysed using a combination of blunt and sharp dissection. The gallbladder was grasped and dissected from the liver bed. The cystic duct and cystic artery were identified, clipped, and divided. The gallbladder was removed via the umbilical port. Hemostasis was confirmed. The operative field was irrigated and no bile leak was observed. All instruments were removed and the incisions were closed with absorbable sutures. The patient tolerated the procedure well and was transferred to the post anesthesia care unit in stable condition. Estimated blood loss less than 50 milliliters. Specimen gallbladders sent to pathology. Complications none. Disposition to post anesthesia care unit in stable condition. Okay, coders, this is your turn. You have 30 minutes and you can ask. I'm going to turn my mic off because I don't want to distract you, but go ahead and chat with me. If you have questions, please, I'm here to answer. I do want to reiterate the instructions. Number one, you're going to need to code all codable diagnoses. Number two, identify which one is first listed. Of those diagnoses, tell me which one is first listed. Number three, code all codable procedures and indicate which one is primary. All right? So maybe I should write it somewhere. Okay. The time is you have 2 more minutes, but I just want to tell you that you all are doing an amazing job. The fact that you stayed was incredible. Now, I did plan on showing the answer, but the answer key, let me just double check. The answer key is, I think we're sharing it with you. Let me see. I see you all in here. Let me go in here and share the answer key. Okay. All right. So I am not going to show the answers. It is on the answer key. And I just want to thank you all and just know, use this resource if you are in, let me find my, 1 second. Okay, so if you come to these sessions and we kind of give you the, it's not letting me move forward. Come on. There we go. All right. So when you come to these sessions, um, it's important for me to answer your questions because it's easy for us to just keep talking and not really listen. So 30 minutes is for me, 30 minutes is for you. But I want to let you know I'm going to drop the answer key when I get finished. So you'll see the answers. And I think it was on the other one, the one that I gave you. But if you didn't see it, good, because I'm going to ready to give you the answer key. All right, but today just want to review that we learned in a basic way how to abstract codable documentation from a medical record. We emphasized ICD-10 CM, CPT coding, guidelines, and we didn't really talk so much about keyword concept, but it was integral. And we did a practical application exercise. And I believe only one person may have put their answers in the chat. You did a fantastic job. And Nina, yes, I sent you a message. Hopefully you'll see it. I gave you the instructions. So, just to let you know, this will be a playback, I hope, and you will find the link for this exercise in the description. Okay? Not right now. You got to give us a moment for it to process, but it will be there. And next week, same bat time, same bat plays, we're going to do the following. We're going to review this homework, question really quickly, and we're going to learn about emergency department coding. So this is facility coding, but outpatient hospital, emergency room. It's really unique. It really is. And we're going to do some exercises to test your knowledge, and we're going to assign you more homework. We're going to get you coding on your own. So I just want to thank you for attending the basics of, oh, yes, Barbara, you got it. There you go. I just want to thank you for attending the Basics of Coding and Operative Report, the AMCI Way. And I want to invite you, when you come to our channel, make sure you like it. Like it. Um, Tell your friends about it. And next week, we're going to be here. All right, someone. Oh, awesome, Nina. Okay, so that's all for now. I did have a little technical problem, but that you see it's getting better. Next week is even going to be better. I want to thank each and every one of you. This was a fantastic class, and I'll see you next Thursday. Take care.